like kind of an adapter.
Well, I have another adapter. I mean,
You know.
I have two things going on here. One is Frasier's. Yeah, whatever this is. Let me just first connect this again. So.
So the live stream's up and running right now.
Okay.
It's just running from a new link.
Okay.
So,
And she's going to email everybody.
She can email everybody. There's already one person viewing. So usually people will they'll be on the channel and then they'll see there's an active live stream, then they'll just switch over to it.
All right. So you've got that.
Should be able to click that.
Till everybody gets here, it's going to take 10 minutes anyway. So you shoo the crowd in here.
Are we
Okay.
good on seats? How many people would you guess are in there?
How many people are there's actually a nice crowd.
Yeah,
There is.
it looks great.
I thought there was more coming. Oh, there you are. One too many times. I was going to ask
We're
if
probably about it's probably going to be full.
Okay.
That's
I
my
just
guess.
didn't know if I should
I
stand.
didn't count. Well, we might end up doing that. But we'll see.
All right. Let's
I'll make sure this is
Figure it out.
slow, right? It's,
email.
It's
That's what I
good.
want.
Let me actually do something. I need to plug.
But you're good.
Oh, I
Make sure my
can't email.
phone's plugged. Did it go
Yes.
on? Yes. It just
You
takes
can't
a
email them
second.
Well, I can't
wanna
sign
make
out
sure
of
that my-
Caitlin's.
Oh, I had brought an extra.
Can I?
plug.
No.
Here we go.
Right. I can't.
Go into Safari. I would use a different way. Oh wait,
And where's
you're in
my phone?
Safari. What's this?
This is
Chrome?
Safari. This is Chrome.
Where's,
Okay,
can
good,
you
yes,
put
you
my
can
phone
do whatever you
for me,
want,
please? I'm
Safari.
gonna leave it literally right here. By, oh, how do we silence notifications on the phone? Because the last thing we need is.
Just turn it.
Yeah.
Should be the side button.
I took some pictures at the thing.
Thank you.
No, I need the messages not to pop on the screen.
Oh, go into airplane mode. Well, no,
No, we
then
can't.
that'll block.
There is a way, hang on.
Turn notifications off.
I put mine on the night thing.
Yeah, but I can't, because this is our
Oh.
hotspot. There we go.
We're actually using Mary's phone for the hotspot, so we're not using this as a hotspot.
But everything is connected.
Yeah, hers I
Yeah,
think
but
is
this
still.
connected. Yep.
Yeah.
Announce notifications. Nope.
Nope.
I think we are disconnected. Oh, yeah.
Yeah, go ahead. Thank you, Matt.
Yeah, if we had had more time, I couldn't find a place for us. This was like a last
Yeah.
minute thing. Because when
I
Fraser told
know.
me like what, 2.5
2 weeks ago.
or 2 weeks ago. I'm
I
like,
know.
We were just like, okay.
okay. Yeah, I guess it's an okay going on. So I hope you guys think this is okay, but I think it's great. It's really,
I love it.
great. And you know what? Everybody shows like what you do. And that's what you can do. I love it.
Thank you. I see nothing about that. I was fine as a fact about it.
I think this is going to be so good to get you out there. That's why I pick out that good one. I really need it, you know?
And I appreciate you guys being here because this is like amazing to be able to, for people, a lot of people don't even know that Bobby Jones exists.
Yeah,
This is Henderson.
that's very
I'm gonna
true.
Put this in our backpack so that we take it with us. we have to do this. Oh, I'm gonna put it in the backpack, and then when we pack up, it has to go to Frasier, and he's gotta walk out with it in his hand. It's patient's films.
They used to be my old clinic. Really? Mm-hmm. You should see the size of this back room here. This is like violence. And there are 3 treatment rooms back there. They have a water infiltration, and I went and then breathed.
So I'm really excited about the I'm so ready. Are we okay with the live stream then? Great.
Start on the computer can be on silence, right? Because we don't need,
Correct.
so in case.
Yeah, nothing will ding
Oh,
them, that'll be okay.
Okay.
And you turned off your messaging, right, like your.
I turned it off over there and things are blinking here and
That's
not
okay.
showing
Yeah,
there,
that's right,
so.
that's okay.
You wanna dial my phone? Let's just do a
I do a test.
A little test.
Okay, 1,
954 394 41 1. I'm
Got
pretty
the
big shoes to fill, you know, guys. I am coming, yes, here, but it's moving here, that's
We
perfect.
stayed at Doubletree,
I have pretty big
and they
Oh,
give
you
you.
always get that warm cookie.
because coming after Fraser is like,
Oh, you're gonna,
I'm not
Razzle
kidding.
dazzle.
Coming after Fraser is like, you mean nothing. And you're like, just everyone, let's go for dinner. All right. It's a big shoe to fill. I can do that.
Oh. Why is Zoom opening?
Great.
Okay.
Getting messages off and talking there.
I don't want Zoom. That's weird. Okay. Let's do.
My patient's taking pictures of. Apparently the screen is online already.
It is.
Yes.
We're live.
We're live.
Is the mic off?
No, the mic is on. Hello, everybody at home listening. We'll be getting started in just a few moments.
Very nice guy. Very professional.
Oh my God.
Please make sure your seats are in their locked and upright position.
Let's see. Hello. Lots of luck. Mostly skill though.
You have a clicker there. I'm sorry. Please consider helping
So can you test the clicker for me,
Okay.
Dr. Henderson?
Does it click or two?
On the right side.
Okay.
I'm sorry.
So nice, guys.
Right? It's all Dr. Perretto.
Yeah.
Yeah.
Looks nice, Dr. Perretto.
It's got all the stuff on the edges.
Oh, well, you can ask
Oops.
presentation.
Stuff around the edges.
Okay.
Oh, it works.
So
Just
then,
killing it.
right.
You had a whole section about
Yeah. So, when the possibly bring back up and
Such a classic ringtone.
yeah. Yeah.
These fine people. Of course, people just register.
Yeah. Right. And, right, right.
Okay.
Yeah, yeah. Yeah, well, that's, yeah, so, okay, well, we'll, yeah, we'll have a conversation. Marcia, and then we can talk with her and Megan.
See, first see what else.
Then we'll see what
Yay.
we can do, yeah. Oh, you did?
Don't worry.
Huh? Oh, is that the other one?
No.
Yeah, and, the first thing is that,
Thank you.
I can run through that.
Park it in.
The best way is super important because so that I can, the safety contract.
Just keep an eye on that.
Yeah.
Just says something.
You wanna, learn about it?
It's all right. Just chew.
Yeah.
Oh, okay. It's,
Thank you. I appreciate it. I just want you to be.
Slide them down.
This is for Dr. Henderson.
A gift for you.
Thank you, thank you.
Why don't you just say hi?
Sure, sure.
I think leave it open.
So, first of all, I want to welcome you all coming here tonight. I'm Dr. Poppy, and I'm the CEO of Buddy Jones Chiari and Amelia Foundation. I don't know if you've been to the website or not, but if you do go to our website, there are 764 videos similar to what we're recording tonight, which is a good resource for business. Tonight, of course, we use amazing video. And honestly, I don't think we get, I don't think we have anybody like this. We don't think like this. Really, Dr. Henderson is an expert, truly an expert for all these years for us. So we're very grateful to continue on to do. He's involved in a number of research projects that we're working on. So I encourage you, I don't want to take too much time, encourage you to go to the site, learn about the research and the education projects that you're working on. If any questions, please reach out to the office. Thanks. And now, Dr. Henderson.
Here.
Dorothy put together the most amazing medical foundation in which there are about 80 nurses around the world. And I don't think there's any other foundation like what she's done. And the lectures, I know about 4 years ago, they've been looked at 1.5 million times. I don't know how many millions now.
We get 10,000 a month views.
So it's a tremendous library. So thank you for the,
I just got a message the audio is not good. The
We're working on it. Thank you.
So thank you, Marcia, for inviting me today. And I'm going to talk about cranial-cervical instability in the broad and narrow context. So, I'd like to honor some of my mentors, Dr. John James, Hannah Furrow, and also Professor Alan Trucker, within my study, did my fellowship in London at the National Hospital for Neurology and Neurosurgery. And it was during that time that we saw a lot of connective tissue disease, rheumatoid arthritis, not much EDS, a lot of osteogenesis imperfecta. And that got me thinking about the whole problem of brainstem and spinal cord injury, something that neurosurgeons didn't really know much about at that time. And we thought that people suffered brainstem injury as a result of ischemia, decreased blood flow due to the pressure on the brainstem. And what we showed in our study, neuropathological study, was that it's actually not so much blood flow as the mechanical deformation, stretch, and distortion. And we published that, and then later published with the Chairman of Cleveland Clinic stretch-associated injury in the upper spinal cord and lower brainstem, which I think is very pertinent to the Ehlers-Danlos syndrome, where the ligaments allow too much stretch and deformity. And then in 2018, we looked specifically at the neurological and spinal manifestations of Ehlers-Danlos syndrome, of which Chiari malformation happens to be one of the more common. And it's important because Chiari malformation, which is this descent of the cerebellum shown by the red arrow through the base of the skull, the frame and magnum that causes obstruction of spinal fluid flow, and also puts pressure on the back of the brainstem. And it's treated with a suboccipital decompression shown on the right, removal of some of the bone. But this commonly occurs with Ehlers-Danlos syndrome. Chiari occurs in 1% of the population, but perhaps only 1 in 1,000 might need surgical treatment. And 13% of Chiari occurring with Ehlers-Danlos syndrome. But more recently, Dr. Santu at Georgetown University noted that 80% of the failures of Chiari decompression had Ehlers-Danlos syndrome. And so he felt that symptomatic cranial-cervical instability should be recognized as a delayed post-operative complication of Ehlers-Danlos syndrome and other connective tissue disorders. So others have hypothesized why decompression for Chiari fails, and a lot of the reasons relate to pressure on the brainstem and deformity of the brainstem and stretching of the brainstem. These are all issues of mechanical deformation, and particularly pertinent to Ehlers-Danlos syndrome. The brainstem deformity, the Fulton effect due to the top of the spine pushing on the front of the brainstem, and Atlantoaxial instability, and of course, cranial-cervical instability, which is the main issue we want to discuss this evening. In Bruckmeyer's papers, approximately, they looked at 100 patients with Chiari, and 20% of these patients needed a fusion. And that fusion was necessitated in most cases by kyphosis or angulation of the brainstem at the base of the skull and facial invagination. So we want to talk about instability at the cranial-cervical junction. And it's important to recognize that any patient with Ehlers-Danlos syndrome has hypermobility in every joint in the body. And hypermobility is not necessarily a bad thing. In fact, it probably makes swimmers faster and sprinters faster. But when it reaches pathological levels, of course, it's very harmful. So hypermobility itself is not necessarily instability. Moreover, if you have radiological findings that might look like instability, it's not necessarily accompanied by neurological changes. So when we say craniocervical instability, it should imply the presence of neurological deficits and pain. If there's no pain, no neurologic deficits, then the radiological findings are not as important. It has to be the whole clinical picture. So just a little basic anatomy here. There's a view through the middle of the brain. And that big bony structure, the base of the skull, that's called the clivus. And at the very base of the clivus is a book. That edge of the bone is called the basion. That will be important in some of the measurements we take. And the axis is the C2 vertebral body, and the axis is the C1 ring underneath the skull. So when we talk about craniocervical instability, most surgeons are thinking about acute instability on a motor vehicle collision or fall from the ladder. And they're looking at these findings. On the left, you see an opening between the base of the skull, the condyle, and the C1 lateral mass. In the middle, you might see lengthening between the skull and the odontoid, that red line, the prolonged basion dental interval. On the upper right, the increased space between the dens, the C2 vertebrae, and the anterior ring of C1. And when that reaches 7 millimeters, that's considered a critical level of instability. And below on the right, you might see the interruption of the pectoral membrane right there. And this is an unstable and stenotic craniocervical junction. So the interesting thing is, however, that acute post-traumatic craniocervical instability actually shares a lot in common with chronic instability of EDS. Namely, you need the clinical data to support the diagnosis. The CT findings are often not reliable. And in fact, the CT may be completely normal. And in fact, especially with EDS, a lot of the radiological findings are very subtle and would be deemed normal by most people. With craniocervical instability, Atlantoaxial instability is very common. That's between the C1 and C2, because they share the same ligaments. So if you have instability between the cranium and the spine, you're likely to have instability in the upper 2 levels of the spine. And in many of these cases, there's an abnormal basion axis interval, and I'll show you what that is in a minute. But if you look on the right there, these little red arrows, all of these patients have a prolonged basion axis interval. So 12 years ago, the Chiari Syringomyelia Foundation, which is sponsoring tonight, brought together these 17 universities and established a consensus statement way back then. The ventral brainstem compression or deformity or kinking of the brainstem dysphagia, difficulty swallowing, and dysautonomia, the abnormal functioning of the autonomic nervous system. And also symptoms of the spinal cord, so weakness, clumsiness, altered sensation, gait changes, even things like urinary urgency and frequency. And third, the consensus agreement was that there were three metrics that would be useful in defining the population who might be appropriate for a craniocervical fusion stabilization. Bilateral angle, the Diagnostic Oaks measurement, and the Harris's measurement. And I'm going to discuss these now. And these three measurements have moreover been validated recently in the Journal of Neurosurgery by Barat and Phelan. Phelan used to be critical of the diagnosed DBS, but now he's published a number of papers on the subject, so it's good that this come around. In that manuscript, they note the importance of performing dynamic imaging in flexion and extension. If you have a ligamentous problem, lax ligaments, it stands to reason that that laxity will be most evident under the force of gravity in flexion and extension. So this is the clival-axial angle, and you see the picture of the brain here. Now we're looking this part here. Here's the clivus, and here's the axis C2, and that's a normal angle. But less than somebody's not coming up here. Less than 135 is pathological, potentially. There may be people with 135 that have no symptoms at all, but when you get less than 135, you're getting into an abnormal level of psychosis there. And we published an extensive review on the subject of clival-axial angle in 2018. Now, the Grad Brooks measurement was actually described by a pediatric neurosurgeon in Alabama, and a line drawn from the basion to the posterior inferior aspect of C2. From that line, the second line is drawn perpendicular from the dura to that line, and if that measures more than 8 millimeters, that's representing potentially impression against the front of the brainstem, and it's an indicator of possibly needing a fusion stabilization. So now the Harris measurement is most important for craniocervical instability, and it's probably the measurement about which neurosurgeons have the least understanding. But back in the 90s, Harris looked at 400 normals, and he found that the distance between the basion and the top of the spine is always less than 12 millimeters on X-ray. And the distance from the basion to the axial line, the BAI, is always less than 12 millimeters. So he said that if either of those measurements are 12 millimeters or more, then you have probably an unstable craniocervical junction. Those measurements on X-ray, 12 millimeters on X-ray is going to be like a little over 10 millimeters on an MRI or a CT scan. But X-ray with magnification. Now, here's an MRI on the left, and you can see the basion axis interval there is more than 15 millimeters there. And you can see that the brainstem is deformed and draped over the top of the odontoid. That's clearly very abnormal. And so that's one abnormal measurement, a long basion axis interval. But another way to look at this is dynamically in flexion and extension. And if you look on the upper right to the left, there's a flexion view, and you see a long basion axis interval. And on extension, that interval decreases dramatically by about a centimeter in this case. And this is the patient down here. Now, normally the basion axis interval should not really change by more than a millimeter more than 1 millimeter of translation is considered abnormal in the non-EDS population. In the EDS population, we allow 3 millimeters of movement, and I think more than 4 millimeters would be considered potentially pathological. And there's a fair amount of literature on that. Now, there's a famous neurosurgeon in India called Atlantoaxial, who's performed hundreds of Atlantoaxial fusions, and who strongly believes that and it's true, that the C1, C2 segment is the most unstable in the body. There's up to 40 degrees of rotation to the left and 40 degrees to the right, and there's up and down motion as well. That's C1-2 is the most unstable motion segment of the body. So he addresses all this attention to that, and he says that the craniocervical junction, on the other hand, is a ball and socket joint like this, and it's one of the most stable in the body. So you may say, well, why are we talking about craniocervical instability if that's such a stable joint? And the answer is because that joint is not stable in the presence of many of these EDS and basal evacuation conditions. There's an excellent manuscript by Huang out of China of 80 controls, 63 patients with Chiari malformation and 42 with Chiari malformation and basal evacuation, the skull-based abnormalities. And in the normal population, there's a very stable ball and socket joint, and there is no evidence of any instability. However, in the patients with Chiari and basal invagination and these other issues we're talking about, there's flattening of this joint, which allows a sliding or translation of the condyle of the skull on the top of C1. So that's how you get abnormal translation between the cranium and the spine. Now, moving down to C1-2, most patients with craniocervical instability also have atlantoaxial instability. And this is mostly in the Ehlers-Danlos population of a rotatory form. And so if we look at we cut the spine right here and look at it from the top, here's C1 and here's C2, and you can see that these bones have almost rotated off one another, and that's almost a dislocation there. So this is a rotatory subluxation. That's what we most commonly see with EDS. And when it does that, it makes the spinal canal very small, obstructing spinal fluid flow and sometimes compressing the spinal cord. But if you look at this on an X-ray from the side, it may look quite normal. So it's a little confusing to people who are not familiar with rotatory subluxation. And this is due to abnormality of the alar ligament. And Chris Centeno in Colorado and his group are famous for trying to improve the strength of that ligament with stem cells and so on. So that's the alar, and here it is on the coronal front view in black, and here's a alar ligament that's broken right there. And so we can diagnose rotatory instability with a rotational CT scan. The patient lies on their back supine on a CT, with the head rolled to the right in this case. And you see the C1 ring is rotated in the middle view, 85 degrees. And the C2 vertebra is rotated 40 degrees. So the difference is 45 degrees. And that angular displacement is 45 degrees, with 41 degrees being the threshold. So when the angle between C1 and C2 exceeds 41 degrees, then you're in the realm of potential rotatory subluxation. And we can do a 3D CT, and you might notice this area here, that's the first set of C2, and it's almost uncovered by the set of C1, so that's almost dislocated. And so when you lose that coverage, when the percent sublux that much, my threshold is 90%. When there's loss of 90% of coverage, then you have instability. Another way of looking at instability at C12 is with the DMH, the digital dynamic fluoroscopy, and looking at an open mouth view, you can see the C1 ring here sliding sideways off C2, and you might see a gap there of about 6 millimeters right there. No, the normal person slides no more than 1.6 millimeters, so our threshold is twice that, 3 millimeters. If it's more than 3 millimeters lateral translation, then they might have Atlantoaxial instability. So I'm going to give you the results of craniosacral fusion stabilization of 53 patients with Atlantoaxial syndrome. And the indications are the presence of a severe headache, more than 7 over 10, the presence of a cervical medullary syndrome, which we discussed, brainstem, and spinal cord symptoms and findings, the neurologic deficits, which include the lower cranial nerves and vision and vertigo, and weakness, sensory loss,